gastroenterology from King Fahad General Hospital, and she's going to talk with us about how to deal with a patient complaining of dyspepsia. Welcome, Dr. Ashwaq.
Assalamu alaikum wa rahmatullahi wa barakatuh, and good morning everyone. Thank you for Dr. Arij, in fact I've been so honored by standing here today. I've been so honored by standing here today. For that I would like to thank the SGA organizing committee for this invitation. And as Dr. Arij said, my topic today is going to be about how can we deal with a patient with dyspepsia who's presenting to the primary care clinic. So before I start my presentation, I would like to show you two consultation samplers that we commonly receive from outpatient clinic. The first consultation is about 27-year-old lady who has insignificant past medical history. Presenting for the first time to the primary care clinic with postprandial fullness for 2 years duration. The pain is partially relieved by ranitidine over the counter, and she had unremarkable systemic review. And the purpose of consultation was for endoscopy and further management. The second consultation is about a 56-year-old gentleman who presented to the primary care clinic with a 6-month history of epigastric pain, early satiety, and loss of 8 kg of his body weight. He's diabetic, he had ischemic heart disease, and has both knees osteoarthritis that is requiring non-steroidal anti-inflammatory use. His labs showed hemoglobin of 11 gram per deciliter with microcytic hypochromic picture. The purpose of the consultation was to evaluate the patient for possible endoscopy and further management. So I believe that dyspepsia is a very common disease affecting large number of population, and maybe most of us has suffered the symptom of dyspepsia at least once throughout our life. And the incidence of dyspepsia is around 50 to 70% in general population, and more than 60% of all GI complaints are related actually to dyspepsia. In primary care clinic, there is 5% of their patients are complaining of dyspepsia, and 40% of this 5% are at increased risk of secondary consultation, invasive procedures, and probably unnecessary medications. During this presentation, we will go through the definition of dyspepsia, natural history and course, etiology, and how can we approach a patient with dyspepsia. Regarding definition, there is no standard definition for dyspepsia, but one of the proposed definition is it's a chronic or recurrent pain or discomfort that is centered at the upper abdomen. But this definition cannot be applied to all of our patients, as some patients may come to us complaining of fullness, bloating, indigestion, or even sometimes nausea and vomiting. Anyway, patients who will present with a history of heartburn and acid regurgitation should be always considered to have gastroesophageal reflux disease until proven otherwise. Dyspepsia, as we already said, is a common disease with extensive differential diagnosis and heterogeneous pathophysiology. It comprises 70% of all GI complaints, and dyspeptic patients usually tend to remain symptomatic, with 60% of those patients are requiring medication and around 43% undergoing invasive procedures, which indicate extensive use of medical resources. Etiology of dyspepsia can be either organic or non-organic, which is functional dyspepsia. In organic dyspepsia, the structures that can lead to symptoms of dyspepsia are found at this area, namely the liver, the gallbladder, the duodenum, the pancreas, and the stomach. So any disease process at one of those structures can be excluded most of the time by careful history taking, physical examination, and labs as needed. In functional dyspepsia, again, there is no standard definition, as this is a cluster of symptoms rather than a disease process that can have a definition. And the ROM3 committee has proposed the ROM3 criteria, which define dyspepsia as one or more of the following symptoms: postprandial distress or fullness, which makes the patient feel pain at the epigastric area after a regular size meal, or early satiation that prevents the patient from finishing his regular size meal, epigastric pain, that is not related to meal, or epigastric, not retrosternal burning sensation. The ROM3, the patients should not have any underlying structural disease that can explain the symptoms of the patient, and the criteria should be met for at least 3 months, and symptoms started 6 months prior to diagnosis of dyspepsia. The ROM3 has subdivided dyspepsia into 2 groups, which is epigastric pain syndrome and postprandial distress syndrome. In the epigastric pain syndrome, the patient will complain of epigastric pain, burning at least once a week. Sphincter of Uri criteria are not met, which are in brief biliary type of pain, mild transaminitis, elevation of bilirubin alkaline phosphatase at least twice the upper limit of normal, and radiological evidence of dilatation of the biliary tree. This criteria should be negative in the patient who is having dyspepsia. Then the lower esophagus and other parts of the abdomen should not be involved. The pain should always be intermittent, not a constant pain, as constant pain always most of the time indicating underlying pathology. In postprandial distress syndrome, the patient will complain of postprandial fullness or early satiation with a regular size meal, as we said already. The significance of this subclassification is not well established, and there is a lot of overlap between the 2 syndromes. To manage patients with dyspepsia, we have to always understand the physiology and the pathophysiology of the disease. The physiology of the stomach, in brief, when the food comes to the stomach, it will lead to relaxation of the fundus, and the whole stomach will distend to accommodate the upcoming food. Then the food will stay in the stomach for a highly specialized mixing process. After that, the food will be pushed down to the duodenum in a process that is called emptying process, which takes 2 to 6 hours depending on the type of food. In functional dyspepsia, the pathophysiology is not well understood, but there are multiple hypotheses. The most common one is stiff fundus, which is a fundus that fails to relax with the presence of food in the stomach. The second one is hypersensitivity of the stomach to distension. Delayed gastric emptying, and other theories are hypersensitivity of the stomach to acid and duodenal hypersensitivity to the fat. For approach of a patient with dyspepsia, we will group our patient into 2 categories: the elderly patient or patient with alarm symptoms, and young patient who is having no alarm symptoms. The alarm symptoms are, I believe everybody knows, is unexplained weight loss, anemia, dysphagia or adynophagia, persistent vomiting, previous gastric surgery, or history of peptic ulcer disease. In the first group, unfortunately, age has been always known as an independent risk factor for increasing the risk of most malignancies. So the risk of malignancy will increase with age. For this group of patients, empirical therapy is not acceptable at all. So any patient who is older than 55 years or having alarm symptoms, the gold standard is doing endoscopy for this patient. So they should be directly referred for endoscopy. The second group of patients, we have medical and non-medical therapies. Among the medical, empirical PPI trial or H. pylori test and treat strategy. Then we will talk a bit about the role of endoscopy in those patients and the role of patient-physician interaction. In the empirical PPI trial, the patient should be started on standard doses of PPI for 2 to 4 weeks duration. Then we will check the response of the patient. If the patient responded, we will continue the treatment for 6 to 8 weeks. Then we will stop the therapy. If symptoms recurred after stopping the treatment, then we will do endoscopy. We can consider endoscopy for those patients. If the endoscopy is found to be normal, then we will keep the patient on long-term PPI or PPI as required by the patient. For patients who do not respond to the initial therapy in the first 2 to 4 weeks, they will go for H. pylori test and treat strategy. In the H. pylori test and treat strategy, we usually use simple non-invasive methods like urea breath test or stool antigen for H. pylori. And in both methods, the patient should be off any anti-secretory therapy like proton pump inhibitor and probably H2 blocker also, and should be also off on any antibiotic at least 2 weeks before doing the test. Blood tests are not recommended to be used to test for H. pylori as the result may be falsely positive in a patient who had remote infection and no underlying active infection. The patient who tested positive for H. pylori should be treated, and eradication should be confirmed after finishing the course of therapy. Eradication of H. pylori will result in symptom resolution in patients with dyspepsia in about 40% of those patients. So, which medical therapy is the preferred starting regimen? In fact, it depends on the prevalence of H. pylori at different areas. So, in areas where the incidence is more than 10%, we will use the test and treat strategy. In areas where the incidence is less than 10%, then the empirical PPI trial should be used. How about our country in Saudi Arabia? Is there any studies that has studied the incidence of H. pylori in Saudi Arabia? In fact, yes, there are around 3 to 4 studies, and most of them has showed 40 to 50% risk of H. pylori in our area. This is one study from Saudi Medical Journal that was published in 2006, examining the prevalence of H. pylori among patients who had peptic ulcer disease, and the incidence was found to be around 55%. And this is another study from King Fahd Central Hospital, Jizan, studied the prevalence of H. pylori among patients who presented to the clinic with symptoms of dyspepsia, and again the incidence was around 54%. So in our country, test and treat is the preferred starting regimen. Now we will discuss the indication to do endoscopy for this patient and how endoscopy can affect or change our management in this group of patients. Most studies have proved that 57% of patients in this group will have normal endoscopy, and another 37% will have minor abnormalities, and in both conditions our management will not be changed. Some physicians may think that the patient will psychologically improve after doing endoscopy and being convinced that the endoscopy was normal. The studies that has been done on this issue showed no variable change in satisfaction score after doing endoscopy in this group of patients. On the other hand, the disadvantages of doing this procedure is that it's being an invasive procedure requiring sedation, which has its own complication, and the cost, of course. So in conclusion, endoscopy was not superior to any of the empirical treatment strategies, and most studies failed to support the view that endoscopy alone improved patient outcome in dyspepsia compared with other empirical strategies. Now we'll move to the last point in management of those patients, which is patient-physician interaction. The patient-physician interaction is considered the cornerstone in management of those patients. If the patient will understand his disease very well, he will learn how to cope and when exactly he should come to the clinic or to the emergency department. And this slide shows the vicious cycle of patient-physician interaction. The patient will always come complaining of pain, and he will be given symptomatic treatment without any interaction most of the time by the physician. The patient will have symptom relief for a few weeks or a few days, then the symptoms will recur, mostly after stopping the medication. He will get frustrated, frequent ER visits and frequent primary care clinic visit. The physician also may get frustrated, and unnecessary medication can be prescribed. And all this issue can be solved simply by giving the patient adequate instruction about the disease. So the patient-physician interaction is a very important issue. So in brief again, an elderly patient with alarm symptoms should go directly for endoscopy, and in a young patient who has no alarm symptoms, we will use the test and treat strategy followed by empirical PPI therapy, endoscopy as needed, and patient education is the cornerstone in those patients. In refractory patients with functional dyspepsia, reassessment and reassurance is always useful, as we may find new findings by reassessing and re-examining the patient. Regarding the diet in this group of patients, there is no linear relationship has been found between any type of food and provocation of symptoms of dyspepsia. Some studies have shown some relation between high-fat meals, so it's better to be avoided by this group of patients. Frequent small meals can be tried in the patient, and avoidance of food that can trigger the symptoms. In fact, I used to ask my patient in the clinic to make a list by the food that can trigger their symptoms so they can easily avoid it. Non-steroidals has been linked to provocation of symptoms of dyspepsia, so better to be avoided again. Proton pump inhibitors, economic models suggest that PPI are cost-effective and superior to placebo in a patient with functional dyspepsia. Prokinetics, they have 50% relative risk reduction compared to placebo, and this is actually query. Not all studies have shown the same result. So I think those medications should be preserved for difficult-to-treat patients, especially patients who have early satiation, repeated nausea and vomiting without alarming symptoms. And of course, this is because of their side effect profile. Other theoretical drugs that has variable response and for which studies are still lacking are drugs that can relax the fundus, like sumatriptan. Tricyclic antidepressant and amitriptyline did not show actually any benefit in studies that has been done until today. Psychological therapies and hypnotherapy is a promising field in this issue. Shall we consider more investigation in a patient with refractory dyspepsia, looking for underlying disease? Like gastric emptying study, would it benefit our patient? The studies showed that even if we improve the gastric emptying in those patients, their symptoms will not improve. So finding delayed gastric emptying in the patient will not change anything in the management. Celiac screening, eosinophilic gastritis and duodenitis can cause symptoms of dyspepsia, and they can be ruled out most of the time at the time of doing endoscopy. Ultrasound, it's not usually recommended to be done in the absence of biliary colic. pH monitoring study can be done for those patients, as around 20% of patients who have functional dyspepsia may have gastroesophageal reflux disease. But the benefit of doing this study is debatable, as the patient has been already taking the treatment that can cure a patient with gastroesophageal reflux disease, and he did not show any improvement of the symptoms. Chronic intestinal angina should be ruled out in a patient with typical medical history, like patient who is having ischemic heart disease, atherosclerosis, diabetic and hypertensive patient with recurrent vague abdominal pain. So in summary, dyspepsia is a very common disease affecting 70% of general population, and no treatment is standard for all groups of patients. About 60% of patients will remain symptomatic despite all modalities of treatment. Any patient who's older than 55 years with alarm symptoms should go directly for endoscopy. Patient education is the cornerstone in management of a patient with dyspepsia. This diagram is showing the management of both group of patients. An investigated dyspepsia patient, if the age is more than 55 years with alarm symptoms, the patient will go directly for endoscopy. If the patient is younger than 55 without alarm features, we will check the prevalence of H. pylori. If it's less than 10%, we will go for the PPI trial. And if the PPI trial, we will do the test and treat strategy. If again the patient is still symptomatic, we can consider endoscopy. In the other group, the patient in the areas where the prevalence of H. pylori is more than 10%, then we will use the test and treat strategy. If the patient failed to respond, we will use the PPI trial. If the patient again failed to respond, we can consider AGD in this group of patients. And thank you.
Thank you, Dr. Ashwaq, for saving us 2 minutes. I would like to